So the next speaker is not available online at the moment. We'll try later also. In the meantime, I will request Dr. Bernard Michael Loeffler to come on the stage and deliver the talk. Dr. Loeffler is from IMM Institute for Mitochondrial Medicine in Germany, and he's going to talk on the use of curcumin, resveratrol, and other natural compounds in tumor therapy, a case report. Dr. Loeffler, please.
Mr. Chairman, dear colleagues, I'm very happy to be here, and I would like to thank the organizing committee, especially Professor Barty, for inviting me. Now it's better. And I would like also to give special thanks for all the people who have made this conference possible, with working in the background, and they did really a very great job. So I would like to start saying something shortly about me. When I was active as a scientist, I had a very broad spectrum of areas of interest where I was working in. So maybe some things, I was very active in endothelin. So in my lab, bosentan, or the trade name is Traclair, was found and developed. And so we solved the first DPP4 crystal structure very fast in our working group, but since 2005 I have changed sides, if you want. I am treating patients, so I am looking at the things from the opposite point of view, and what has been discussed here today and also on the other INCD conferences I've attended, I try to put in praxis for my patients. So I don't know whether I can really give you some inspiration for your work, because what you are doing here, when we put it into praxis, is very important. So there is one book about cancer which I love most, and that is the book from Mukherjee. Sorry, I don't know whether I pronounce the name right. And I read to all of my cancer patients this short fraction of his book. It is more in the introduction. And it is telling that cancer is not just a monoclonal disease, it is an evolving monoclonal disease, and every new generation of cancer cells will lead to some cells which are genetically different, and because of this, the standard working and treatment principles are not going to work, and patients have to know that. Because the paradigm, one illness, one target, one drug, is a pharmaceutical paradigm, and it is just there to earn money, but it is not there to win, and it is not there to help patients. Yeah? There is not only the cure of chemotherapy, and there is not only the way of the oncology conferences, which are always, and I know that since 17 years, deciding the same. They are not deciding individual therapies for individual patients. They are deciding something which guarantees pharma industry to calculate today what they will earn in 3 years. And that is our problem. That is our biggest problem. And that is the problem why what is discussed here and developed here is not taken into praxis. I will show you here a very simple thing, which I will come back to that, with measurement of circulating tumor cells. You see in the upper right, I don't know where, here. Don't know whether you can see this. You can see here in the upper right the suggested chemotherapy for a colon cancer patient which is metastatic. And these are the two chemos which are normally given, and they have an effect of 13% in average or 21%. So it's clear that they will fail, but that is what the patient is offered. So when we combine this chemotherapy with agents which we were talking about here in the last days, curcumin or so, then you can see that you can improve the activity of this chemotherapy dramatically. But when you look then, you can also see, when you compare just these two lines here, that without chemotherapy, the effect of alternative agents is much, much better as with chemotherapy. So we had yesterday a talk which were going in this direction, that chemotherapy can do something but also not doing the same. And when you combine alternative things, then you can also see that you improve when you are taking more than one drug, and that is all speaking for a multi-drug approach. So then it is always said by standard therapy and standard medicine that curcumin is not working because curcumin has a bad bioavailability. Dr. Sriraj Gopi and me, we have been the only ones comparing so far in a human pharmacokinetic study 3 compounds which are on the market, and the only intravenous curcumin which is on the market, which is shown here briefly. And as I showed you here, so the intravenous curcumin, that is the upper one, and curcumin active are nearly the same active, and they are active for 48 hours. That is what we have measured. So you can really use them as a treatment. And for the IV curcumin, there is in the meantime a clinical study available showing its activity. So when it is always, and as that is always what I hear from standard oncologists, be said that curcumin, for example, it's just an example, will not work because of bad bioavailability. This is simply not true. I have contributed to one English book where also Professor Agarwal is in the editors, where I have a chapter about curcumin and how to look at what you can achieve with different curcumin formulations. The other one is in German because German physicians just read German and not English. And to educate them, you have to follow them and to write in German. So I have showed you at the beginning results from circulating tumor cells. I will very briefly go to the 2 labs with which we are working, measuring circulating tumor cells. So this is the one, and what they are doing is sketched here. So you have a blood sample, and within the natural environment of the blood, you are looking for EpCAM-positive cells, and then you are counting these EpCAM-positive cells, and then you can look with which agents you can interfere with these EpCAM-positive cells and kill them. So the other one technique is a little bit different. They are purifying out of the natural blood with magnetobead technique the circulating tumor cells, and then they are also measuring it, but they are not measuring the death of the tumor cells, they are measuring the decrease in ATP use. So the cells which are not living anymore, they don't need any ATP anymore, and then it is transformed into a concentration-dependent inhibition plot of what you get. So that these tests to measure circulating tumor cells are predictive for the evaluation what compounds can be used in the treatment of a tumor individually for the patient. This has been shown. This has been shown on more than 5,000 patients, but it is not taken into consideration in standard tumor therapy. So, as we are using 2 different laboratories or 2 different techniques, and this is because of redundancy, I show you here a comparison, and I show you that both labs coming to the principally same results. So that means this is a cross-reference that what we are measuring here is really of some importance. So now I come to the case I want to show or want to discuss with you shortly. This is a case of a patient who came to my praxis first time 2015, just with some general questions concerning his general health situation and preventive checkup and so on. This patient, the most severe problem of the patient was an allergic bronchitis, which he had since childhood, and which was treated with corticoids since childhood, and this maybe is also the reason for why he developed cancer. So he came back in 2019, also just with a different question. He had found his wife, they wanted to get a child and they couldn't, so that was the question, but we made for safety reasons an X-ray of his thorax, and we found that the whole left lung wing was full of cancer, so world changed within 12 hours for this couple and for this patient. And so I was not bound to the general ways of treating patients as this is true in Germany but also in America. So because I have my private practice, I'm just bound to what the patient wants, and there's a big difference and it is a big advantage. So immediately we started big biochemical evaluation, and we also started to look at possibilities to deal with this cancer, which was at that time even not characterized. So what I show you here is very general. It is not just for cancer patients. You see here a huge chronic silent inflammation. So all these inflammation markers here are severely up. Yeah. You see, and you see here, this is all these markers, all these different markers, which we also have talked about yesterday. They are all up. Patient has no idea about it, but they are making cancer. So, and then when you look at different parameters, then you see here that this patient has a severe vitamin D deficiency, yeah, makes cancer. So the most important thing from vitamin D is normally not discussed. Yeah, it is free 25-dehydroxy. That is the thing what is finally making the goal, and it is very low. The reference values have changed in the meantime. They are much higher. When we started to measure this, we were one of the first doing that sort. And then you see down here that 3 vitamins, B1, B2, and B6, are severely deficient. So B1 deficiency makes cancer, makes dementia, makes a lot of things, but it certainly does make the mitochondria unfunctional. Vitamin B6 is involved with the glucose metabolism. If you have none, you have pathologic glucose metabolism. Vitamin B2 is needed for the pyruvate dehydrogenase, so without vitamin B2, no energy production. So it's a disaster, and this disaster you find nearly in 70% of well-nutrition patients which are coming to my praxis. So they are already at the upper level of their income, and even so they have it with the nutrition which they are having every day. So this is producing not just cancer, it is producing chronic diseases all over. So we made with this patient before, as I said, we didn't know the final histological diagnosis, already a test for what could interfere with his cancer on circulating tumor cells. That is what you see here. And you can see here already that, for example, curcumin had an effect of 85%. Thereby, it was better as all the pharmaceuticals which are normally used in whatever colon cancer. But you also see that we looked for circulating tumor stem cells, which you can also do with one of these assay setups. And we didn't find at that time circulating tumor stem cells, which was good. That is something I will not go into details. So within 5 days, the patient went into surgery. It was a complete removal of the left lung wing, and together with 12 lymph nodes, and it is called an R0 surgery because from the point of the surgeon, he has done everything, no cancer has been left. So, and then after the surgery, and I show you that just here because you see how much the number of EPCAM cells, these are tumor cells, if you want, went up from 150 to 1,600. And this has something to do with handling the tumor. Yeah? If you are handling it, I mean, when you want to make the surgery, you have to handle it. Then the tumor sends around in the circulation huge amounts of tumor cells. So it could be a signal for metastasis already doing this. Yeah? So one, for example, could think about doing something preventive before surgery or so, but in standard procedures, all these things are not done. So and I'm showing you here, you know this case has in the meantime 5 folders. So I cannot present to you here 5 folders, but I present you here results of circulating tumor cells over time, and you can see they are reproducible. Yeah? So even when the number of cells is going down after the surgery back to 350 cells and then to 200 cells, so what you find in terms of sensitivity of the cells is more or less the same, and you see also more or less that chemotherapy is not the first choice. So also shortly after we got the histology, and this patient has a very rare lung cancer. It's about 2% of normal lung cancers. He has a carcinoid, and it is put into the folder of neuroendocrine tumors, even so that specific PET scans, for example, have been always negative on this patient. So, and what we did already from the biopsy, which we got the day after the diagnosis, is we made a severe molecular screening. So we sent the part of this material to a specialized lab, and so the report is 58 pages long, also not something for here, but the summary is standard chemotherapy is not the first option. So that was already clear from this report. Then we had a big discussion with standard medicine whether this result is valid, because it was just from a small biopsy of this huge tumor, and the reality might be completely different. So therefore, we performed from 9 of the tissue samples we had from 3, and from the 12 lymph nodes from 2, by random selection, again screening for molecular characteristics of this tumor, and all the specimens showed the same as from the first from the biopsy. So, and all showed again that chemotherapy radiation is not the way to go. Even so, the Charité, that is the big Charité in Berlin, yeah. Oh, sorry, I did not translate it then. Sorry. I gave a talk recently. They suggested chemotherapy radiation. So, because, you know, in standard thinking, there is nothing else than chemotherapy radiation. So, there is no guideline for this tumor. There is no first-line chemotherapy for this tumor. And when you look at literature, the literature tells you that you should not do chemotherapy. But the standard is the standard, and it is suggested. And in this special case, yeah, it is the worst what you can do, because the patient before had already lung problems, yeah, with this chronic inflammation, and the risk of chemotherapy radiation for lung patients is that they are developing lung fibrosis, and so they are dying from the therapy. And there are a lot of papers showing that, but you know, when you are just able to think standard, yeah, then this doesn't matter, because normally a lung cancer patient anyhow doesn't live longer than 12 months. So, yeah, and that is, it is unbelievable, yeah, that people who are dealing with this day by day are not able to think out of the box and to realize that there are other options. So we made a lot of additional analyses with circulating tumor cells. This is relatively bad to see, but you can see that we also tested combinations. And at the lower here, you see methadone. Yeah, methadone you might know as therapy for pain therapy. Yeah, and it is known that when the opioid receptor is mutated, then the opioid receptor has a big impact in tumor growth, and one can see here methadone is working. So we came to a therapy scheme, yeah, where we heavily increased his vitamin D level. He got resveratrol, he got curcumin, he got once a week a curcumin infusion, and he got methadone and he got silymarin, because silymarin improves the pharmacokinetic of methadone. So with this, we kept this patient in a good way till November 2020. Control MRTs have been negative, yeah, and then the patient didn't want to take methadone anymore for what reason ever. He has decided he needs a break, and I could not convince him not to do it, so he stopped it. And in February 2021, in the next control MRT, he had a small positive lymph node. It was really small, just 4 millimeters. Normally one would not look at it, but in this case we did. So the patient underwent selective proton therapy for this lymph node, but proton therapy has a risk of, because it's like as if you put an atom bomb in the middle of a city, so everything is exploding. So it has a risk of spreading, and it has a risk of creating metastasis. It can be very helpful, it can be also very risky, and exactly for him this happened. He got cutaneous metastasis, and so then the Charité again opted for chemotherapy. In the meantime, the patient had the stem palliative, that means everything is lost, you cannot do anything anymore. Besides the fact that he's playing tennis, he's doing very well, so he is not behaving as a palliative patient. So, but I mean, that is what they did. And I show you here again results for the suggestions. You see here for the first time the 2 sites. So this is the next oncology group, and you see here the amplification of tumor genes, which are done with these purified circulating tumor cells. And here you see the results of the suggestions of the Charité in terms of chemotherapy, with combinations and alone, and you see it does not work. It does not work simply, yeah? So, but, you know, if you are a Charité professor, then you are in a position with your white coat that you can just disregard everything, yeah? You does not have to look at real facts. So
5 more minutes.
Yeah, I'm ready in a minute. So we have remeasured also what we are doing, but we also measured 2 new possibilities, ONC201 and ONC206. And you can see with these 2, yeah, here, and also we have remeasured methadone, and you can see methadone is still in the top, going up to an effect of 70%. So, but these are really promising. These 2, they are relatively new, and maybe you know that or not. So we also, again, in one panel measured the suggestions of the Charité with our other compounds, so that one cannot say, so this is one assay, this is another assay, so it's not comparable. And so at the end of the day, we are decided for a combination therapy with ONC201, curcumin, resveratrol, artesunate, and methadone. So that is a multi-target therapy. And now you might ask, what is ONC201? And then we are here at a curcumin conference. So this is the target of curcumin. Yeah, this is the death receptor, or the trial way. So this is known since a while. And ONC201 is exactly something, it's a new generation of therapeutics which is interacting with this receptor. There are at the moment, I think, 126 publications around that. And there is one clinical study, that is this one, showing in human that it is working. So, and we are doing this because I don't have to wait until this has been officially recognized by German standard medicine. That is, as I say, an advantage. So, I recommend to you this book. from Daniel Kahneman. It is the newest one. It is from 2021, and it has something to do with human judgment. And the chapter 5 is dealing with medicine. And if you read it, you will find out why we have so many problems at the moment with our standard medicine. Yeah, the judgments simply are wrong. So I want to sum up with saying, so we are always in cancer facing individual situations. Every single cancer patient has a different cancer. The classification in receptor positive, receptor negative, HER2 positive, it is wrong, it is too rough, it is not getting to the point. Every breast cancer patient has to look at singularly in her special situation, and if you want to win, you have to have a therapy which is pointing to this single situation. So that means the guideline medicine which we are still performing is running in the nowhere. It will be never successful. The only one for whom it is successful is Big Pharma, and that is the tragedy. Thank you very much for your attention.
Thank you, Dr. Loeffler. So, any questions? Anybody has any question? So individual treatment for individual will be okay, but the number of cases are so much. Do you think it will be possible?
You know, this patient we have treated completely without standard therapy. I have a lot of patients where we are doing a combination. So I have principally nothing against the chemotherapy, but the chemotherapy should not be performed blind. Yeah, the chemotherapy should not be performed because of the guideline. The chemotherapy should be performed on the basis of measurements. So when you show that you have a 70–80% reduction in tumor cells with whatever chemotherapeutic, then yes, then we use it. And then we look for how we can make it more effective by adding, for example, curcumin or resveratrol or whatever else. Yeah. So, but performing chemotherapy on guidelines, that is the point. What I want to make is wrong. You have to measure it in the forefront, and we can measure it.
All right. Thank you very much. Thank you.
You're welcome.